Thank you for coming. I think we should probably get started. We're going to talk today about a very common condition that affects millions and hundreds of millions of women worldwide. How is that possible that there's such a condition that affects that many people and still is not as obvious that there are treatments for these things, for these conditions? Patients live with a lot of these conditions commonly because they feel they have this common misbelief that it's a normal condition. So urinary incontinence is just one condition that affects millions of women that is not normal. It's common. And then today we're going to talk about a lot of the current therapies and management strategies we have for this. So let me introduce myself. I'm Dr. Peter Castillo. I'm the director of the Urogynecology Specialty Center at the Vital Health Institute here in Los Gatos. I'm also an associate clinical professor at Stanford University School of Medicine. And I'm double board certified in obstetrics and gynecology, as well as female pelvic medicine and reconstructive surgery, formerly known as urogynecology. Some of the objectives for today, we're going to talk about what the urinary system is, how it works, and how it leads, and how it functions normally, and get a better understanding of how these symptoms that patients present with how they lead to a diagnosis and treatment. We're going to discuss what we're currently doing for a lot of these conditions, and then at the end, hopefully we'll have enough time to answer as many questions as possible. And if you have any concerns about asking questions out loud, we can step aside and talk a few minutes about any particular questions you might have. So, what is urogynecology? Urogynecology is a subspecialty field that focuses primarily on disorders of female pelvic floor. So pelvic floor disorders are very common, including urinary incontinence, bowel and defecatory dysfunction, pelvic organ prolapse, sexual dysfunction, among other things, including traumatic and iatrogenic injuries that happen to the pelvic floor in women. And this field arose because of the dire need for a comprehensive approach to managing these conditions. It's not just a gynecologic problem. It's not just a urologic problem. This requires a formal and a thorough understanding of how these two systems work. And that's where the urogynecology field came to be. So what we're going to talk about today is urinary incontinence, in particular stress urinary incontinence. So urinary incontinence just as a whole just means involuntary loss of urine. So this is not a normal condition. It's not normal at any age to leak urine because of activity or because of an overactive bladder or other reasons for leaking. Urinary incontinence is common but not normal. And it is extremely treatable, and we have lots of therapies to manage the different types. So there's various types of incontinence. It's not just I leak and therefore you have this. Incontinence happens for a variety of reasons. Most commonly, your stress urinary incontinence and urge urinary incontinence are the most common types. Stress incontinence is not stress like nerves. It's stress like strain. When you bear down, when you cough, you laugh, you lift something heavy or sneeze, that's that increased intra-abdominal pressure onto your bladder that then causes leakage. Why? Because the outlet or the urethra doesn't close well. So if you imagine the bladder is like a balloon, and the neck of the balloon is the urethra. When you fill the balloon with air and you close the neck, the air stays in. If the neck doesn't close, or if you can't close it automatically in a normal way, the air comes out. What's very similar to that analogy for stress incontinence, because the pressure inside the bladder can't be stronger than the urethra. The urethra has to stay closed. So stress incontinence is a urethral problem, which means it's a mechanical problem. Then there's urge incontinence. Urge incontinence is a problem with the bladder itself. It's not the urethra. It's not a mechanical problem. It's more of a neurologic, physiologic problem with the bladder, where the bladder is a very strong muscle that we trust our entire lives to do what it's supposed to do, serve as a reservoir, collect urine, so that we can time when we want to go to the bathroom. That's under neurologic control. The central nervous system controls the bladder, keeps it at bay, and lets it fill as a reservoir to allow us to store urine until we're ready to go. Problem is, what happens if we lose that control, that neurologic control, that leash on the bladder, so to speak? If that's off, what happens to the bladder? The bladder is a muscle. It does what all muscle wants to do. It wants to contract, and it will empty. And that's urge incontinence, not a mechanical problem, but a physiologic problem. Overactive bladder is that constant need to go, that urgency, frequency, constantly needing to go to the bathroom. Some patients will go 11 to 12 or 15 or 20 times in a day because they can't get rid of that sensation that they need to go, even if there's nothing in their bladder. They go frequently during the day, they have frequent urges, then they get up multiple times at night. That's called nocturia. And they may or may not leak. So overactive bladder is a kind of an overall encompassing condition of an unstable bladder. And then of all the women that have incontinence, that have stress and urge, guess what? About half of them have both, or describe both, symptoms of both. So it's very difficult to know where to start. As I mentioned, stress incontinence is a mechanical problem that the treatment is based at the urethra, whereas overactive bladder and urge incontinence is focused on the bladder, and treatments for bladder are more physiologic, medical, physical therapy, and behavioral modifications. The management is so different, and patients, yet half of them will complain of both symptoms. So it's very important that we distinguish the two through thorough evaluations and diagnostic evaluation to determine what really is the condition so that we can treat it appropriately. Otherwise, like many women, you end up chasing your tail for a long time until you figure out that's not the problem. There's other types of incontinence that are less common, overflow incontinence in those patients who are unable to urinate, or urinary retention, usually due to traumatic or neurologic injuries to the bladder. It doesn't empty. So much like a cup, if you keep filling it, at some point it's going to run over. And then there's continuous urine loss, which oftentimes has to do with anatomic causes, meaning either congenital malformations at birth or iatrogenic or traumatic injuries that happen down the road due to trauma or surgery that led to a continuous loss, as if there's no middleman, there's no control over the urine, the way it comes out. We're going to focus today on stress urinary incontinence, but overall, urinary incontinence is so common that we say that 1 in 3. 1 in 3 women, if you look to your left or your right, one of you, or maybe neither of you, will have some form of urinary leakage, whether it's bothersome or not. But someone in your row probably does. And it's that common of a condition that so many people oftentimes chalk up to, well, that's sort of part of life, isn't it? My mother had it, my aunt had it, my sisters have it, so why would I question whether this is abnormal or not? Because nobody talks about it. Oftentimes, when I diagnose patients with incontinence, I ask them about their family members, and they'll say, no, but I've never asked either. And that's very common, because if you don't ask, people won't tell. And because it can be an embarrassing thing to complain about, patients don't even talk to their doctors about it. So because of that, we feel that there's an underdiagnosis of urinary incontinence generally. It's probably even up to 40% or more. Why do we know that? Why do we suspect that? Because national surveys conducted by the National Association for Continence found that only 1 in 8 Americans who have experienced loss of bladder control have ever been diagnosed. Can you imagine that? Only 1 in 8. Where are the other 7 doing? They're just assuming they have a condition and they don't talk about it. We don't know. Women experience symptoms for, on average, according to national surveys, of 6.5 years before being diagnosed. In my experience, it's been closer to 10 years on average. But that's looking at patients that have had these conditions for 30 or 40 years, always assuming it was normal. And if you look at that, only half of patients that would ever indicate to their doctor or their nurse that they actually have this problem really is telling about how quiet of a condition this is and how many people live with this in silence. So let's put this in perspective. If you really wanted to find out how does urinary incontinence compare to other conditions that we really worry about, like life-threatening conditions or common chronic conditions like Alzheimer's disease, osteoporosis, diabetes, I'm sorry if that's not clear, and asthma. Look where urinary incontinence and overactive bladder lie. It's 37 million people in America with urinary problems that are silent. A big chunk of these, a large proportion of these women are very silent. Why is this important? This is important because urinary incontinence, although it's not a life-threatening condition, has a huge and tremendous impact on a patient's quality of life. So quality of life is defined as loss of joy in the activities that we do, or inability to participate in those moments that give us joy. So quality of life loss to anybody is a detrimental effect lifelong. So how do you know if it's really having an impact on your quality of life? Well, ask yourself these questions. Are bladder control problems always on your mind? Are you really thinking about what if I go too far from a bathroom? What if I don't empty my bladder before the house? You're now shifting your focus on your daily activities to one concept, is how am I going to avoid having a problem while I'm out? Do you find yourself staying near bathrooms, wearing absorbent undergarments just in case? Patients map bathrooms, And it's interesting. If I ever need to know where a bathroom is, I can ask any one of my patients. They'll know exactly within a few hundred feet where the next bathroom is from in any direction. And that gives me an idea of how much this is a focus on their life. It's really unfortunate. Patients often stop doing their own activities, things that they used to love to do. They used to love to garden, or they used to love to play tennis or golf, or just go for walks. But if they can't do that because they're concerned of leakage or wetting themselves or having an embarrassing moment when they're in public, they're going to stop doing that. And that's a problem, because then your health starts to deteriorate because you're no longer exercising and being active. When you turn down invitations for family or friends, or afraid to spend the night at a family member's home because what if you have an accident in their bed? These are embarrassing moments that patients think about and stop doing things. And these are the things I hear. These aren't made up. These are things I hear from all of my patients over the many years, that each time I hear them, I feel that there's something's got to be done about getting the information out to patients, that this is not normal and that we have to do something. So let's talk about the urinary system. Urine is produced by the kidneys. The kidneys are filters. They filter your blood. They get rid of waste, and we excrete urine in the form of waste in the form of urine. It happens throughout the day. No regular schedule. You're always producing urine at all times. The ureters are conduits or tubes that drain the urine into the bladder, and the bladder is a reservoir, so that we can control the timing when we go to the bathroom. Otherwise, we'd be constantly making urine. So urine is made constantly, but it's stored in the bladder so we can go at regular intervals at our decision when we feel that we need to go. And the urethra is the outlet. Urethra is the balloon, the neck of the balloon, that allows the air to come out, allows the bladder to empty. So how does it normally work? There's a lot of things that go into play to maintain continence. The bladder, the urethra, the pelvic muscles, and the surrounding connective tissue, not to mention the neurologic system, and the voluntary will to be able to control our normal functions, all interplay in the storage of urine and emptying of urine. What keeps us dry? So this is a different way of looking at it. Let's look at a side view, and let me just demonstrate what this is illustrating. This is your body from the side. So imagine you have a little window from the side that you can see how your pelvic organs are oriented. Here's the front, your pubic bone. Here's your bladder over the urethra. The uterus over the vagina, and the rectum over the anus. These three organ systems share this small little area, and they support each other and depend on each other for support. The pelvic floor is the bowl that sits at the bottom of everything. So the very lowest part of our pelvic cavity, which is the lowest part of our torso, that absorbs all of the forces of daily activity, go on top of our bladder and then on top of our pelvic floor underneath. So you need a functioning pelvic floor to hold and to also give us continence, because what it does is it contracts reflexively when we cough, when we bear down, without us thinking about it. We don't have to do a Kegel for that to work. That's the normal function. If the puborectalis and the levator ani, the pelvic floor muscles contract and close this angle. They close the rectum, they close the vagina, they close the urethra to prevent leakage of stool, urine, and to maintain pelvic organs. So this is the normal effect. When you have any impact on any of these structures, the urethra, the bladder, or the pelvic floor, then of course you're going to have problems. So this is the normal function of the bladder. The bladder is allowed to fill. The neurologic system makes it relax. The bladder cannot increase tension or pressure. It's like an endless balloon, not really endless, but relatively endless balloon that will not do and cannot contract because it's under the control of the brain and the nervous system. Once we've gone to the bathroom and decided to urinate, we're going to sit down and relax our pelvic floor and silence the urethra, and guess what? The bladder contracts and we empty. Sounds simple. It's a very complex problem that we take for granted our entire lives because it always works. When it doesn't work is where the problem is. So, as I mentioned, the normal physiology is the bladder has to have a lower pressure than the urethra. Once you have that change in pressure where the urethra no longer is strong enough to withstand the pressures of the bladder or the pressure on top of the bladder, that's what causes stress incontinence. As I mentioned, the pelvic floors play a big integral role in maintaining continence under stress. And the urethral support, which isn't just the pelvic floor musculature, but it's also the vaginal supports. One of the common things that happens in women as a result of many of the common events that occur in their lives is relaxation or weakening of the pelvic floor muscles, as well as the supports that hold up the pelvic organs, including the reproductive organs. So relaxation of the vaginal walls, also known as prolapse, where the bladder or the back wall of the vagina or the top of the vagina can fall, weakens those supports underneath the urethra. And now, even if your pelvic floor can contract, they're not aligned well, so that you still leak. So pelvic relaxation is extremely important. Pelvic support is extremely important, not only because of pelvic support, but also the urethral support immediately underneath it. So what happens, like I mentioned, is lack of ability for the urethra to close is what causes stress urinary incontinence. Remember, it's a mechanical problem. So the bladder, and I've never figured out a good way to diagram this, so I'm going to show you with my hand. So my bladder is, my hand is my bladder, and this is the urethra. So the urethra is a tube that drains your bladder. When you cough or laugh or sneeze, normally it closes like a garden hose because you have normal pelvic floor support, you have normal urethral support, and it closes. That's a normal mechanism, physiologic, and keeps us dry. When you have loss of that support, that vaginal support, the pelvic floor support, instead of it closing, it swings. That's called hypermobility. So increased mobility, because there's lack of a backboard support, allows for the pressure to transmit right through the urethra and patients leak. That's how stress incontinence occurs. And the other way, it's not as common, about 20% of patients that have stress incontinence because the urethra itself doesn't close. Excuse me. The urethra is a muscular tube that's supposed to stay closed, and will always stay closed unless we relax and the neurologic system allows it to open. But patients who have severe types of stress incontinence where the urethra does not close, it's called intrinsic sphincter deficiency. And that's more a common problem with neurologic injuries, but it is also common as a late effect of aging. But either way, the result is a mechanical inability to close the urethra. So in a patient that has that dysfunction, where the urethra doesn't close, now even if you're trying to tighten up, you cough repetitively, and what happens? There's not enough support under the urethra and you leak. It's very different than urge incontinence, and I'm not going to get too much into it because the management strategies for urge incontinence are a lot longer. But for urge incontinence, it's very different. It's an urgency preceding leak. A lot of patients that describe both urge and mixed incontinence because they tend to have both symptoms, but they don't know what caused it. If you cough and you're about to leak, you're going to have some urgency as well. But urge incontinence by itself is leakage preceded by an urge, not by an active or physical event. You didn't cough or sneeze, you're washing your hands. You're putting your key in the door. You're pulling in the driveway, and all of a sudden that incredible urge comes over you, and you know if you take a step, you're done. You're not going to make it. That is the common description of urge incontinence that patients will often report. And as I mentioned, that's a physiologic problem with the bladder, where the bladder fills and reaches some trigger volume and says, that's enough for me. There's nobody holding me back, and it contracts, and you empty. Why do these things happen? Why are urinary problems so common? Well, there are a lot of risk factors that contribute to them. The unfortunate truth is that a lot of women undergo very similar life events. Having children, strenuous work, overweight, chronic coughing, chronic constipation, any chronic increased intra-abdominal force can weaken those pelvic floors and lead to stress urinary incontinence or prolapse. And that's why it's so common. There is a predisposition in some patients to have prolapse or incontinence without any of those risk factors. And those are the more concerning ones, because there's clearly more to it than just what we see and what we normally do every day. So now what? How do we treat these? So we're going to focus primarily on stress incontinence, but on the table outside, I left some information for you, if you picked it up or if not on the way out, that goes over some of the strategies for both for managing of urge urinary incontinence, bladder retraining, and then even some information for prolapse if you're interested, because a lot of these are tied together. But we're going to focus mainly on stress urinary incontinence. I always recommend a conservative approach first. Why? Because it's only going to benefit you, even if it's not going to be the end-all, be-all for your particular degree of incontinence. But it is important to maintain a healthy lifestyle. Weight reduction is very important. Did you know that if you reduce only 10% of your body weight, that reduces your incontinence events by 50%? So if you're leaking 6 times a day, That's down to 3 times a day. Maybe it's less. So weight reduction is always important. Decreasing caffeine, it's a diuretic. You don't need to be adding fuel to the fire and then wondering why you can't get this under control. Fluid intake is misunderstood. The concept of drinking 8 to 10 glasses a day is a myth. So there is no evidence to demonstrate that drinking 8 to 10 glasses a day is actually necessary, because urine is not supposed to be clear. Urine is supposed to be amber. A light amber is fine. But clear means that you're drinking in excess, and all that excess is coming out in urine. That's why it's clear. And you'll notice that elite athletes that drink constantly, because they're constantly being dehydrated during their exercises, they'll urinate clear urine, but that's how they know when they're ready to go and dehydrate themselves during their race. But aside from that, that's not a normal occurrence. It shouldn't be dark orange either, because that means you're not drinking enough. Drinking 3 to 4 glasses a day, combined with a well-balanced meal, will give you all the fluid that you generally need. And of course, the caveat to that is those who are frequent stone formers probably need to drink a little bit more, so they're in a catch-22. And those who take particular medications that are filtered or cleared by their kidneys should also make sure that they drink enough. Kegel exercises, pelvic floor exercises are very important, because it's not only urinary incontinence that we're treating. We're preventing or minimizing prolapse. We're managing bowel control, which is also very important control, that as we get older, bodily functions sometimes are not as easy. And if we don't have good control and mastery of our pelvic floor tone and contractions and being able to do them, how are we going to learn later on in life? So it's important to always do them throughout the day, do them every day from now and forever, is what I always say. Pessary is an artificial way of restoring that support under the end of the urethra. It's like a diaphragm. It's a small appliance that's placed inside the vagina that sits directly under the urethra and gives you that backboard support that I described, a normal physiologic support. It's pretty effective. It's about 60 to 70% effective on average. Some patients a little bit more, and some patients a little bit less. But the nice thing about a pessary is that it's non-invasive. There's essentially no risk. There's no surgery involved. And it works. If it works for you, you can continue to use it for as long as it works. The downside to pessaries is, like I mentioned, effectiveness is around 70%, because this is an extrinsic force that's placing on the urethra via the vagina. And 2, it does require care. It's not a permanent fix, meaning it sits inside the vagina and gives you support, but it does need to come out periodically to clean, either yourself, the patient, or by their own physician to take it on a regular basis for cleaning and putting back in. If it works for you, if it's comfortable and it's doing what it's supposed to do, it's something that you can use for as long as it works. The nice thing about it is that it's fully reversible. If you don't like it, you can always just take it out. Bulking agents are another modality that we've been doing for decades. We used to use collagen, and it's specifically used in select patients. Those who are really severe incontinence, those who have had radiation therapy and their urethras are completely immobile, it's a fantastic procedure, minimally invasive procedure that is useful for those patients. We are finding a role for it in the mild incontinence patient as well, but generally it's recommended for the more severe patients who may have failed other procedures or are not tolerant of surgery. It is still effective, about 60 to 70% effective, which in patients who are leaking constantly, in these patient populations especially, it's better than what they were doing before. There is no pharmacologic therapy for stress urinary incontinence. So there are no medications for stress incontinence. There's plenty of bladder meds out there, and a lot of times because patients don't understand what their symptoms are, they can't tell if it's stress or urge, the go-to knee-jerk response by some doctors to give you an anticholinergic medication, which are medications for bladder control. That's useful if that's what you have. But if you have stress incontinence, it doesn't do anything. It has no effect on the ability to close the urethra. So here in the United States, there are no current medications for stress incontinence. As I mentioned, doing Kegels every day prevents incontinence, or at least allows you to guard, if possible, by tightening up that pelvic floor. This is a different view. I didn't have this earlier for you, but this is, imagine if you're inside the abdominal cavity and you're looking down at your bottom. So this is looking down at the pelvic floor. This is your pubic bone. This is your tailbone, and you're looking down from the inside of your body, and this is your bladder, your urethra. The bladder is not shown here, the vagina and the rectum, and here's that pelvic floor. So when you tighten the pelvic floor, before you sneeze, because you had some warning that you're going to do that, and you're able to guard, it helps close the urethral angle and may minimize your incontinence. That's why Kegels are always good to do. So how do you know if you're squeezing correctly? Basically, some patients can actually stop their urine midstream. I think it's a little hard to do sometimes. The bladder is a very strong muscle. And I try not to give my patients that as a goal, because it sets them up, many, for failure, thinking that they're failing because they can't stop their stream. It doesn't mean that you're not doing them right. It just means that it's a strong bladder and it's very hard to stop once it's moving. It's like trying to stop a moving train. So what I prefer to recommend is patients, we all understand this. If you have gas and you're surrounded by people, imagine that you're in an elevator and you're surrounded by people and you have a lot of gas. What are you going to do? You will squeeze until you're blue in the face to make sure that the gas doesn't come out. Everybody can do that. That's a Kegel. That's exactly what a Kegel is, but you give it a name and people get confused. It's tightening your pelvic floors. It's not pushing, it's not straining, and it doesn't move anything. It's what you do when you squeeze your anus, which is really your pelvic floor, and it closes the angle. That's why gas doesn't come out. So it's the same thing you would do if you wanted to prevent leakage from coming out if you could guard. So this is an example of what continence pessaries look like. They come in different sizes, shapes, and styles. These are only 2 of them. And they are very comfortable. Surprisingly, many patients, actually not to me, but to many women, they're surprised to hear that a well-fitting pessary is comfortable and is almost imperceivable, meaning they aren't aware that it's there. Many can have intercourse with them in place. And as I mentioned, they're effective, about 70%, but they do require care. Bulking agents, this is an image of what a bulking agent looks like for that patient who has failed, has a more severe type of incontinence, or can't tolerate surgery. And we do this in the office where we plump up the urethra and gives it resistance, increases the resistance here. There's about 60% improvement. We used to do this with collagen, and collagen was great because it was pretty harmless as long as you weren't allergic to it. Problem with collagen, it goes away in about a year. So that means you have to repeat it every year. So we no longer use collagen now. Now we have better products that last longer, much more durable, and very good outcomes. About 60% effectiveness as well, but with the promise that they may last longer. As of right now, data shows that they're at least 2 years out, if not longer. But every patient's different, because the patients who benefit from bulking are usually the more severe patients, which tend to progress and get worse over time. So it's really hard for me to tell you how long it would last. It would really depend on the patient and their severity. But it's done in the office, 30-minute procedure, very relatively comfortable procedure that we do in the office all the time. And then that brings us to surgical procedures. Surgery has always been the gold standard for incontinence, but it's taken many forms over the many decades, because our understanding of the pelvic floor, our understanding of our continence mechanism grows every day. And with each decade, we discover new things about our treatments that, you know what, that was great as it was. 50% then was fine. Nowadays, 50% is not acceptable. 75% was great for the last couple of decades. 75% is not great for the patient who's still wearing pads and wants to be dry. So that constant drive for cure, that constant drive for improvement of patients' quality of life is always the goal. So that's why we continue to push the envelope and look for newer developments. So for the last 20 years, we've been doing mid-urethral slings. Mid-urethral slings is a hammock. Basically, it's a hammock that restores that normal mechanism that I described to you before. Remember the bladder, and here's the urethra. When you cough or laugh or sneeze, when you have normal support under the urethra, it should close like a garden hose. You remember that? So what we do now with the mid-urethral sling is basically we place a small hammock under the urethra. It doesn't change the angle of the urethra. It doesn't change the orientation of the vagina like other procedures used to do. All it is a hammock under the urethra that doesn't fail. So when you cough or laugh or sneeze, it restores that continence mechanism, that very normal and natural physiologic continence mechanism that we've lost, that patients have lost when they have stress incontinence. It comes in various forms. There's retropubic mid-urethral slings, transobturator slings, which go through around the groin, ones that go behind the pubic bone, and then newer single incision slings, which have been demonstrated to be equally effective for routine stress urinary incontinence. I wasn't sure how this image was going to show. I couldn't find one that was bigger or better, but So here's the uterus and the vagina, here's the bladder and the urethra, and here's the pubic bone. And see, this is a retropubic sling, which shows a sling, a hammock that goes under the urethra. It doesn't change anything. It's not operating on the vagina or lifting the top of the urethra or the bladder like the Birch procedure. It's just a normal hammock so that when you cough, you don't leak. Extremely effective, close to 90% effectiveness, and we'll talk about that in just a moment. So it's a minimally invasive procedure, helps correct the incontinence using a permanent material. Why are we using permanent materials now? We've been doing slings for decades in various forms. We used to do needle procedures or retropubic bladder neck procedures where we would use tissue that we obtained from our own body. We would get connective tissue from the abdomen, from the inner thigh, and we would use that to create the same hammock effect that we just described. That hammock effect works. Problem is, when you use your own tissues, they tend to fail over time. So the success rates over time deteriorate. And because of the inelastic nature of our own connective tissue when it's suspended that way, it created a lot of voiding dysfunction, meaning difficulty urinating. So traditional pubovaginal slings or sling procedures, when we were using our own tissues, had their ups and downs, and we had to harvest tissue from another part of the body. Had to get it from your inner thigh or from your abdomen. So now you have another wound. So when we moved to mid-urethral slings, the reason why we did that is because now we're having outcomes that are lasting as long as the sling is there. And because it's a permanent material, it doesn't go away. Slings nowadays are all of the same type. They're type 1 polypropylene mesh. What that means, the type of material is the same kind of material that we use in the eye, we use in the abdomen, we use for hernia repairs, we use for prolapse repairs both vaginally and abdominally. We use it in the permanent suture when we're using permanent suture that we use in all kinds of surgeries. It's proline, it's polypropylene. So it's the same materials that we use. It's just designed to place and sit underneath the urethra in a way that's natural and allows your own tissues to incorporate. So when we used older models of slings in the past, we used different materials that weren't so accepted because the pores were too small or they weren't elastic enough. There's various variations of the development of a sling, but we've been doing these current slings for nearly 20 years with great efficacy because the material is essentially inert. The body doesn't recognize it as foreign. No one's allergic to it, and no one essentially rejects these. And it's as wide as my finger, and I'm going to show you a big picture, but it's as wide as my finger and as thin as a sheet of paper. And it's got lots of holes in it, and those holes are large. Those large holes allow your immune system to work through them, your connective tissue to grow into them, so much so that once they're incorporated, you can't find them. You won't know that it's there. Your partner won't know it's there. Your surgeon or a surgeon like myself won't know that it's there unless you tell them, and they have some reason to be looking for it. But a mid-urethral sling that is well-placed and incorporated, the only way you're going to know that it's there is because it works. And that's why we've moved to that now for nearly 20 years. It's become our gold standard, replacing everything hands down that we ever used to do, including the Birch copal suspension, which still has its role for select patients, but effectiveness definitely decreases in 5 years. So the mid-urethral sling, not counting if you have other conditions like prolapse or anything like that, but just for a mid-urethral procedure, is about a 15-minute procedure, generally done under anesthesia or under sedation, where it's an outpatient procedure. The patient goes home, same day, and it works from the day it's placed. It's not that you have to wait for it to work. Now, there is restrictions that you have to follow following the surgery to protect it, but that's all. Like any surgery, it's like consider it like an investment. You don't undergo surgery for incontinence to treat the condition that you've been dying to treat and now go jeopardize it doing things that you probably shouldn't. So the restrictions are very important afterwards. But for all intents and purposes, it works from the day it's placed. You won't know because you won't be able to test it out. But should you catch a cold and you're sneezing or coughing immediately after surgery, you'll be able to test it out then. But that's not ideal. So we've been using mesh, as I mentioned, for incontinence since the late 90s. Millions of people worldwide have had mid-urethral slings and has replaced all procedures that we know that we've ever done before. Success rates 88 to 94% generally. And the goal is to exactly do this. Restore that support under the urethra so despite the coughing, the sneezing, and the pressure intra-abdominally, you leak. So just to conclude that, because I gave you a lot of information, I hope I didn't go too fast, but it's important that we remember that urinary incontinence is a common but not normal condition that impacts person's quality of life tremendously in a way that those who don't can't imagine. Don't be embarrassed to discuss these problems with your family, because you would be surprised at who's already been treated and just never mention it and they're happy. Don't be embarrassed to talk to your doctors or your nurses, because they may get you to the right person to treat these. It is very treatable. There are various treatment options available depending on the type of incontinence, severity of incontinence. As I mentioned, there's already several different types of slings that we do. And that's, of course, if you've attempted conservative efforts or you cannot do them and they're unsuccessful, ask about ways to make sure that you're treating the right condition and get to the right person for treatment. And the goal is to improve our quality of lives, because bladder problems are not necessarily, you don't have to live with these. There are some additional handouts that I gave in the back, as well as some online information if you'd like to write these down. National Association for Continence is a very huge, very large, well-organized organization that promotes information, health information for patients for incontinence of all types, both male, female, bowel, and bladder. Take the Floor is a consumer website for the American Urogynecologic Society, which is our leading American society for pelvic floor disorders. Live Life Dry is an excellent source for some of the products that treat urinary incontinence, and they have lots of data there to explain how they're superior to other products. And the Vital Health Institute, of course, is where I work. Our website is recently launched this week, so there's still some information missing on there, but keep checking periodically. There will be greater and greater information there for patients. Thank you so much, and I appreciate your time, and of course I welcome any questions that you have. Anybody want to?
Oh, I have a question.
Sure.
I was a patient.
Yes.
Kaiser.
How are you?
Anyway, I've had a lot worked up and I've had a sling, but it's been a long time ago.
Okay.
And it's still, because I don't remember. But can it still be done if I had a sling, and could it possibly help?
Sure. I'm sorry, I don't recall. I do recall your face, but I don't recall when we met. But slings, they, as I mentioned, when they're placed properly, they're almost imperceivable. So if you had a sling that didn't work in the past, doesn't mean that you couldn't necessarily have another sling if that's the condition that needs to be treated. So for patients who've had prior slings that aren't as effective as they were, or were never effective, usually doesn't mean that it's not still a good option for you. But the first thing I would always recommend is make sure the diagnosis is correct. Either have urodynamic testing if you haven't had it, or repeat urodynamic testing, because, as I mentioned, many patients have both. Stress incontinence can be treated, and then urge incontinence can persist. So the treatment is very different. So that's what I would recommend. So yes, so if it is stress incontinence, yes, you could have a sling procedure, but it all depends on the severity and type, and there, like I mentioned, there are other options like bulking procedures, that type of thing, for patients who are refractory to slings. Sure. Yes?
So I had a bladder suspension over 20 years ago, which was after hysterectomy. How does that differ, and does that fail?
Yeah. Well, back before the 90s, we were doing birch copal suspensions primarily. That was our gold standard for many years, and that was our comparison. When we started developing mid-urethral slings, we compared everything to birch because that was our gold standard. We had an 80% success rate for the first 5 years, and then about 75% afterwards. But then what happens is, over time, it deteriorates even more. So beyond 10 and 20 years, birch procedures really tend to start to fail. So we don't do them that much anymore for a couple of reasons. One, they're a lot more invasive. They require either abdominal approach or laparoscopic approach, which has a slightly lower success rate. But when you do them, The right kind of incontinence will do well, like a mild form of incontinence. But lots of studies have demonstrated that severe forms, meaning that spectrum of stress incontinence, where you get onto the close to the more severe range, Birch suspensions or Copal suspensions don't work as well. So some patients will say it just didn't work enough. Some patients say it worked for about 10 years and now it's not. So the solution to that is have it be evaluated to make sure that we're trying the right type of incontinence, and then determine if a sling is the right procedure for you. Because generally, repeating a Birch is probably not going to be the best answer for you. And I'm sorry, I don't know if I answered how is it different. So it's different because when you place, what you do is, remember, here's your bladder and here's your urethra. The Birch suspension, the goal was to try to artificially create a kinking mechanism. So here's the bladder and the urethra, and we would suspend the bladder neck with suture to the pubic bone. So what that does, unfortunately, the unfortunate side effect of that is it fixes the urethra, and it can't move, and it makes this the fulcrum, the bladder. So the downside to doing Birch procedures is that it fixes the urethra in a non-physiologic way, and it gives you an artificial kinking mechanism that results in prolapse in 15% of patients after a Birch. So many patients have had Birch procedures, 15% of them will have prolapse de novo. It didn't have before. So that's one of the reasons why we kind of stopped doing it, whereas a sling doesn't do that. A sling doesn't fix the urethra. It doesn't change the angle of the vagina or the top, or the bladder neck. It literally sits and reinforces the normal physiologic bladder urethral support that the pubourethral ligaments used to do. The ones that you lose when you start to swing like that hypermobility, it's restored by doing a midurethral sling in a much faster and more directed procedure. Any other questions? Well, I'll be here for a few minutes. If you have any questions, please feel free to walk up. I don't bite, I promise. And information is up on the back at the back table if you haven't picked it up yet. Thank you.